Very much. Okay, perfect. Let me just get my hands right. Okay. Thank you all very much for having me here today, and I'd also like to add my acknowledgements to the traditional owners of the lands that we're on, their elders past and present, and any Aboriginal and Torres Strait Islander people here today. I'm taking a slightly different journey from Flavia, so we'll see how we go. But similarly, I'm just going to give you a bit of an insight into sort of how I got to where I am by a very random process to end up doing a job that did not exist when I started medical school. And I think that's a really important thing to remember. I mean, your generation is much less fixated than mine on, you know, what's your career and what's your linear path. Make your own path, be curious, and follow your opportunity is basically what I did. So I started being curious at a very early age, and this was my favourite book at the age of 4. I was a very strange child, and I remain a very weird adult, so I guess that bit doesn't change. But I grew up in a completely non-medical family, but at the age of 4, I got absolutely addicted to this Time Life book of the body from the late 1960s. And I used to spend my days reading about Galen and humours and the history of dissection and body systems, and I just thought it was fascinating. It was so interesting. And I actually lost touch with this book, and in lockdown I got on eBay and I got it, and I opened it up and it smelled just like it always smelled, and I went through every single page, and every page I just knew every picture on every page because I'd spent so long with this book. But I knew then I was curious about medicine, and I went through school, and it's like, well, you know, yeah, year 12, I've just got to put medicine. I've got nothing else to do, and there was this slightly freaked out thing of what if I don't get in? And luckily I got in and came here. So that's kind of where it started. But what I ended up doing is nothing like that book, right? So I went through a few things, and this is just to prove to you that once upon a time I was a ranger. I'm now just going grey. But I demonstrated more of my weirdness halfway through medical school, because when I came into Monash it was, you know, a 6-year undergraduate degree, and halfway through I did a Bachelor of Medical Science, because I kind of wanted to get off the treadmill. Like, we used to sit in 7 hours of lectures a day. And I got to spend a year working with Mick Adamson, who had introduced neonatology to Australia, and his fixation was, what do normal babies do? Because everybody, you know, was terribly worried when neonates did anything that it was abnormal and wrong. He said, well, do we actually know what healthy full-term babies do? So I spent a year up on the top left there at the delicate age of 21 studying feeding and breathing in newborns, and did a lot of electrophysiological recordings. Nothing like what I ended up doing, but it was a great year to learn how to learn a lot about something in depth and to really feel on top of a domain, and I loved it. I got really addicted to that feeling. I also met an amazing man who Ingrid may know, Professor Leo Cusson, on the bottom there at my graduation. And Leo was a paediatric pathologist, and Leo just knew everything about everything. Like, you could ask him anything at all. So he was this brilliant, brilliant man, but he also was just the most delightful person to work with. He was everybody's favourite uncle, and he brought a joke to work every week. He would distribute cartoons and comics, and he just brought his whole self to work, and he made work a better place to be. And it's like, yeah, I would like to be a person like him. So I think in our careers we have to find the people we kind of would love to emulate. And then I went through medical school and I did paediatrics, which kind of made sense because I've never really grown up. And I really liked the kids and playing and everything. And that's, you know, our happy little band at Monash Medical Centre doing paediatric oncology. And I went through rotation and rotation. It's like, well, this is really interesting, but do I want to do it forever? It's back to Flavia's repetition story. And I hadn't quite found the thing. And then I got an opportunity to go to Oxford. And I headed over there. I just passed my paediatric exams, luckily by the skin of my teeth, you know, like a month before I was due to leave, and went there and started doing clinical trials. And I was doing clinical vaccine trials, and we were going around to people's homes and injecting kids. And I got involved in surveillance of Haemophilus influenzae infections. And we were running the sort of national database on that. And a strange thing was happening, which was that vaccinated children were getting Hib. They were getting meningitis, they were getting epiglottitis, some children were dying. It was a bad look. this vaccine program had been running for 9 years. So I got involved in trying to understand the root causes of that. That took me between Oxford and London to what was then called the Health Protection Agency, and it took me into some very strange places, because as we tried to understand what was happening with a disease where what you actually observed in terms of hospital admissions was just like the tip of the iceberg, how did you know what the processes were underneath? Because most of the infections that were spreading here were completely asymptomatic and unknown. So I got introduced to an infectious diseases modeller, and that was Professor Angela Mclean, who was in the Department of Zoology. So in the sort of the last year of my time in Oxford, I worked with these two awesome women. And, you know, awesome mentors are the people to find. So Angela Mclean on the left there was in zoology at the time, a professor. She became a fellow of All Souls College. She's now the Chief Scientist to Defence in the UK and has been very important in the pandemic response. On the right is Mary Ramsey, who was in bloodborne viruses and immunisation at the Health Protection Agency at the time. Again, she remains a very senior figure in health policy in the UK, and here is giving a Downing Street press conference throughout in the era of COVID. They were the women who taught me. Like, they were pretty freaking amazing. And I was really, really fortunate because they were both incredibly talented, incredibly able. Every time I turned up, they'd fix that gaze on me and I had to deliver something smart. So that was a scramble. But they also were incredible role models, they were mentors, they were sponsors, and they were my friends. And I think that's a really, really rare combination, but I was so lucky to have those two. And it's still such a great pleasure to see them whenever I'm back in the UK. And that's where I ended up, which is nowhere like I would have expected to be back when I was reading about Galen at the age of 4, or even when I was doing paediatrics or vaccine trials. And from those beginnings in the UK, where I basically, you know, fell into epidemiology by accident, was able to learn modelling and took a gamble. I actually took a pay cut to learn how to do modelling. And Angela actually said to me at the end of that year, she said, you know, if you wanted to do this as a career, I think you'd be good at it. And like, you know, we all love to show our great confidence on stage and everything else, but most of us walk around with imposter syndrome. And, you know, I have plenty of days where I feel like I have no idea what I'm talking about. But if I can remember that Angela said she thought I'd be good at it, it's okay, because she makes a lot of sense. So, I came back to Australia, got involved in building up capacity building networks. Raina McIntyre led that first push back in 2005 and have since led NHMRC Centres of Research Excellence to build up modelling to inform infectious disease control policy in Australia. And over 15 years had worked with the Commonwealth around the H1N1 flu pandemic, but also in a lot of preparedness planning. And in the beginning of 2020, got catapulted into key national policy advisory committees and a whole raft of contracted research. So we were meeting 4 hours a day, 6 days a week, and another 2 hours on Sunday, just for the committee meetings, and being contracted to do the work. And I ended up leading a national distributed consortium, and I'll show you their names at the end, to answer a whole range of questions relevant to pandemic preparedness. And really was thrust into the full light of translation, having previously spent a lot of time advising, you know, policy advisors and bureaucrats, particularly in the second half of 2021, was trotting into the Commonwealth parliamentary offices on a regular basis to speak to National Cabinet, Cabinet committees, National Security Committee and First Secretaries Group. So it was a real learning curve, an enormous privilege. But yeah, 2 years of my life that really took everything I had and everything that I'd learned. But what is it that I actually do? Like, a lot of people kind of find it hard to imagine what a modeller is or does. They're just some nerdy person sitting there, you know, I don't know, writing maths or something. But actually what I do is not a silo at all, which is why I love it, because I hate silos. I'm easily bored and I need to be kept curious. So I like to be in a room with lots of people who do things I don't know anything about, and I like to be the dumbest person in the room. So what we do is a cottage industry, and modellers basically sit and write down and think about the processes that underpin what they see. You know, people getting infectious diseases, there's all this stuff happening between hosts and pathogens, there's people actually getting together, all this sociology and social psychology and behaviour. And what happens in the middle is epidemiology is an emergent phenomenon. It's what happens when people mix together at whatever stage of pathogen relatedness they are. And so I end up working with whole teams of people who come from very, very different discipline domains. Obviously a lot of people from maths, physics, computer science, engineering, but also, clinicians, laboratory scientists, sociologists, political scientists, psychologists, and it's great. And so I'm always having to be curious and learn new things and think about what are the essential processes that we need to be able to represent in what we do to understand how infections spread. And there's a really nice piece in Science that came out as sort of, opinion piece, I guess, in May this year that really talked about, well, what is it that modelling does? There was all this modellers rule the world rubbish back in 2020, and obviously we don't. But what we can do is two sort of types of things. And so because models are interested in phenomena, they're interested in understanding processes and drivers of how things happen, often what we do is quite qualitative. So the work that I do sort of sits on the left there, and it's saying, okay, well, we understand how infections spread, and we've seen how other infections spread. We've got this whole new thing here. What are the basic principles about how it might operate? How does the new information that we have slot in to how we think about these things? What could happen next? What would happen if we did nothing? What would happen if we tried doing different things? And that really then is about setting up strategy. And a lot of what I do is strategy and helping people think through, what the consequences might be. Now, there's another model that's called the back of the envelope, which is just a let's have a guess. This is a principled way of bringing together the evidence that you have and putting it into a framework and playing it forward and being able to experiment, conduct thought experiments about what might happen. On the other side is the much more quantitative side of modelling. This is where we take emerging data, bring together epidemic intelligence, lots of layers of information, and use that to do situational assessments. So we call integrating this information nowcasting, because most of the information we have is already a bit out of date. Where are we actually right now? Are we at the peak yet? That's what everybody wants to know. But also what might happen in the next few weeks in terms of cases and hospitalisations and other things. And James McCaw's led that stream of work over the last 2.5 years. But really the bit that interests me, as I say, I get easily bored, is this whole, what we call structured decision-making framework. And this is kind of the core of what I do. This particular framework's borrowed from ecology, because ecologists do a lot of the same sort of things as us, so we get to play with them as well and pick on their ideas. But, I love doing this piece of really coming down and saying, well, what's the decision we're making? And what's the context in which it's being made? We work in Australia, we work in the region, there's very different political pressures and economic realities and cultural issues. What's the decision we need to make? What's its context? What are the objectives we're trying to achieve? Reducing deaths, reducing hospitalisations, getting people back to work. How would we measure those things? And then what are the alternatives? And so that's then where the modelling process comes in and says, okay, how do we represent the process? How do we put in the alternatives? How do we estimate the consequences? And I don't know why all those weird parentheses turn up in this slide, but they always do. And we can evaluate the trade-offs in these qualitative or quantitative ways. And then that takes us back to the cycle of saying, well, did what we think would happened, or was it something else? So we can implement, monitor, review and come back again. And this really participatory process is what was so interesting to do over the last couple of years of being in the key committees, identifying, defining the problems, bringing in the information and then feeding back to those committees and refining and iterating our approach. And there's another nice, I've done something weird with this, I don't know, there we go. And then there's, this is just a really nice schematic from USAID, which was an evidence review on the incorporation of evidence in policy. And it just takes it that step back further and says, okay, well, you get these people who say, well, the epidemiologist said to do this, why didn't you do it? Well, that's because it's a lot more complex than that. What the epidemiologists come up with and what our models come up with is just one piece of evidence that fits into a policy process. There's a whole lot of different pieces of information and opportunities and capabilities being put together to make these sorts of processes. And there's a whole lot of other stuff that happens, and you learn more about this as you get into the thick of it, about what are the relationships and the power dynamics, what are the political drivers, what's the political pressure, what are the incentives and processes within politics but also in society, and what are the existing knowledges and beliefs. People don't just start with a blank slate. How do you use their existing information to help guide their thinking and shape their knowledge? And communication's everything, and we've learned a lot about that in the last 2.5 years. Always trying to get it clearer, get the message simple, make it clear, and make it relatable. So I'm not going to spend a lot of time talking about this, but I'm just going to give you some highlights of some of the things we did in the last couple of years, just showing how models can be useful in thinking through decisions. And the first ones are just really that strategy thing. So I was literally on holiday with my kids in Castlemaine. It was my first holiday in 6 months. We were away for a week. We'd gone to Castlemaine. Like, I wasn't game to go anywhere out of the state. I get a phone call from Paul Kelly on Friday afternoon while I'm in a vintage market saying, the Prime Minister's just stood up and announced your work plan for the next 3 months. I'm like, oh, really? And it was, you know, the Doherty modellers are going to provide us with vaccine thresholds to guide our steps out of, lockdown into living with COVID-19. And so there was a huge amount of work done really over the next month or two at very short order by a large group of people that really came to say, okay, well, we're immunising the population. What are we doing it for? It was actually really important to motivate people to get immunised, to know why they were doing it, that it would enable greater social freedoms. And also we changed the strategy to say how we should be doing it. But also being quite realistic that at that point, you know, vaccination against Delta was going to help, but we still needed to have some other constraints in place. And this particular figure, this was a lovely piece of communication for policymakers from Nick Golding at Curtin TKI, really saying, well, what is it we're trying to achieve with vaccination and other measures? And what we were trying to do was reduce this metric that's here called transmission potential. And if you've heard of the reproduction number, which I think everybody has now, Scott Morrison knew what it was, it's the number of secondary infections per case, right? And that's easy to measure, or easy-ish if you actually have an epidemic, but in Australia we didn't have much to see for quite a long period of time. So we had to anticipate what spread would be like, and Nick invented this metric called transmission potential that took into account a lot of behavioural and social factors about mobility and connection, and were calibrated against spread in periods when we did see it. So what it basically, the message of this slide is, when the Wuhan strains first emerged, this was the R0 or the transmission potential. It was a bit less than 4. To control an epidemic, you have to get it down to 1. By the time we had Delta, it was 8. And, you know, it's just gone up and up, right? So what was it that was holding things in place? And in Australia, we had really good test, trace, isolate, quarantine, TTIQ. That active case finding was doing a lot to constrain spread. And we also had changed people's behaviours. We had those baseline social and behavioural measures about, you know, 1.5 metre rule and other things. And we were monitoring people's compliance with this all the way through. Those things already brought us back to kind of where we were with the Wuhan strain. But then this is what vaccination might do. And we looked at 50 to 80% coverage. These were the thresholds we were asked to explore. There was a lot of enthusiasm to open really quickly. We said, if you do that, it's not going to work because you're still a long way above the control threshold and you're going to need something else to constrain spread. And so we also looked at the impact of public health and social measures that had been imposed in Australia. High PHSM is full lockdown, but there were other grades less than that. And we said, if you want to open up here, you're going to go into lockdown. You're going to still need to control spread because it's going to take off. And so this was important in encouraging people to wait till 70%, at which point just keeping some social measures on would help, and by 80% we'd be pretty much right. That was for Delta. Obviously Omicron came next, but we won't deal with that right now. But the important piece of this work was we did it with Treasury. And that was so much fun because this whole of government thinking is critical when you're thinking about these responses. And back in 2020, there was this health versus the economy. Gigi Foster wanted to kill all the old people so the young people could get on with their lives. And, you know, there were just awful, unconstructive, polarising debates about these things. So working with Treasury was great because they said, you know what really hurts the economy is lockdown. And if they said if we, you know, reopen at these different thresholds and we have different strategies to managing, you know, some degree of public health and social measures, what's the likelihood that we're going to need to go back into lockdown for how long and how much is that going to cost us? And what they showed was if we reopen too early, anything in red here is a lockdown, and this is how much it costs, right? And in millions per week. And, you know, if we reopen too early, we were just shooting ourselves in the foot because we had these vaccines here, we're rolling them out. If we just waited a bit longer, we'd be able to avert this wasted spending. And actually, by the time we got to 70%, if we kept some restrictions in place, we could avoid lockdown. And then at 80%, we didn't think we'd need them anymore. And so it was a really nice piece of combined work that made the policy. I'm not going to go on too much longer. I have some other examples of things we did that were tactical as well. We did some work on how to use testing. That was quite important. But, you know, also like how to test people in quarantine. A lot of the work that has gone into, you know, easing up primary close contacts to be RAT tested but not have to quarantine came from our group's work. We also did a lot of work with the Aboriginal and Torres Strait Islander Advisory Group, helping to inform recommendations for response in First Nations communities, and also making the case for higher vaccine cut-offs there, a younger age denominator for the population coverage estimate, given the younger population, and really supporting the idea of pre-positioning of antivirals and other therapies in remote communities where access to care was limited. And we also did a lot of the work, Nick Scott here led this work from Burnett around testing in schools. Any of you, well, you probably don't have kids, but if you've got siblings or cousins who are at school, you know, we've got rat tests coming out our ears. But this idea that, you know, one of the biggest issues, particularly for Victorian kids, was the amount of time they spent away from school in the last 2 years. And the initial approach to case and contact management in sending kids back to school, if they all had to quarantine every time there was a kid in class who had COVID, they'd never get back. And what this showed, the metric to look at here was this face-to-face teaching days lost metric was the really important one for policy. We said if we have outbreaks in schools, the big difference here, if we have an outbreak in a school, it's introduced and over the next 45 days, nothing happens. About a third of the time there'll be no outbreak, about a third of the time it'll be big, and in the middle it'll be, you know, something in the middle. But if we quarantine class contacts, we can reduce big outbreaks, but we're going to be quarantining kids for 256 days. That's how many days of teaching is lost. If we let them go to school every day but RAT test them, we have the same outcome in terms of the epidemic, but we only lose 69 days of face-to-face teaching. And that was a dramatic difference, and that was the basis of some of these really supported testing strategies. So all really different curious questions driven by societal need, thinking about the process, working up new frameworks and helping to guide decision making. So yeah, if you start weird, you're probably going to stay weird. Curiosity's been the unifying theme of my career journey. Really important to be turned on and stimulated by mentors and sponsors who help us to see opportunities and find paths, and I took career risks to do things that I thought were interesting and important and where I had the encouragement to do it. Medical training is a really broad base, and as a medic you're a great addition to an interdisciplinary team. We love to solve problems. The best bit of medicine is the formulation and solving the problem, and it's all a bit of a mystery, and it's the same sort of thing I get to do. And academic public health, I don't do clinical work anymore, but for me public health is the feel-good factor. It really enables impactful contributions at scale, and so I don't have to get that one at a time appreciation from my patients, but I can see big impacts at the population level. And just to show you that I don't work in a silo, here are the people who contributed to the work that we did over the last 2.5 years. So when you hear the words Doherty modelling, that applies to a few people who sit in the Doherty, but this is a really big national consortium. So thank you.
Thank you so much, Jodie. It's a very interesting, diverse and timely presentation. We've got a couple of questions online, but I'd like to open to the floor in person first. Yeah, over there.
Thank you, Jodie, for your wonderful presentation. I think it's really informative and very insightful as well. I am trained as a nurse, and also I just completed my master's in public health at the University of Melbourne. And I have always been very intrigued with like the whole public health approach in relation to policy, and just trying to see how we can have those kind of conversations around navigating policy at a grassroots level. Because at the same time, when I did my health policy subject, I was trained by Professor Helen Jordan, and it was really interesting to see how there are many different stakeholders involved in policy making, and in terms of helping to drive policy change, it seems like there is always this ever-evolving, to be honest, it's like an ever-evolving beast in a sense that we are trying to tackle the broader public health issue, but from a grassroots level organization kind of perspective, it seems like it doesn't sometimes sit well with the community. And this is the kind of problem I face sometimes when I work with communities at the moment in my career. So, yeah. How do we tackle that in that sense?
So stakeholder consultation is our bread and butter. In fact, I do refer to my teenagers as the stakeholders. They're my controlling stakeholders. But you're right. I mean, and these things have to emerge organically from a process, and getting the right people in the room and the people who can, meaningfully contribute to that process is important. I think one of the best stories I ever heard from someone who worked in the Victorian Health Department too was that the other real requirement for anyone who wants to engage in policy is patience. And she talked about having a well-stocked bottom drawer. And she said, look, I work in health. These are the things I'm really passionate about. I consult with people. I know these things are really important, but there's just no political appetite for them right now. They're not interested. And she said, but that doesn't bother me. I just keep gathering my evidence and talking to my people and getting these things. And then one day I'll be watching the news and the minister will stand up and somebody mentions my issue. And I can just gently lean in and say, oh, Minister, I hear you have a problem. And so, there is this need to really have this, robust understanding of what's important, but also know how to pitch it and the timing and look for your opportunities. And they can come in surprising ways. But I think that's certainly been the case. Doing pandemic preparedness was not sexy for 15 years. And, my academic institution said, I think you're doing too much service. Where are your big nature papers? Well, I think we made an impact. So I'm glad I stuck with it. Yeah.
Thanks, Jodie. There's a couple of questions online. The first one is, are there any career benefits to learning new skills like data analysis? If there are professionals already with these skills, who can we collaborate with?
Sure. So look, I think across all of the biological sciences, and health is one of them, the need for data skills is just compelling. And actually even in the HAS disciplines, data has just overtaken everything. So having those skills is really useful and important. Like everything else, having communication skills is even more important, but the more strings you have to your bow, the better. And, when people come into something like infectious disease modelling, it's still a cottage industry, it's still an apprenticeship in Australia. There isn't a clear path in. People often come from the STEM disciplines, with clear expertise in coding or something like that, which is great. And we've got to teach them epidemiology. People might come in from public health or other streams and say, I'm really, really interested in this. And then we just have to work with them to say, well, what's the level of your quantitative data skills and help to fit them into the team, based on what they do there. So if you already have coding skills or already have done data analytics or other things, it's so much easier to have visibility into a discipline like this. And that's the data revolution. There'll be plenty of work to do. So it's a good career investment.
And Jodie, you mentioned going overseas to Oxford. Do you think going overseas will allow us to learn more as future clinician scientists or as budding physicians? And do you think it leads to more opportunities?
Yeah, look, I think at a stage in your life when you're free and unencumbered and you can travel and you don't have, a mortgage and kids and all those life responsibilities, I think it's good for everybody to be able to get outside your bubble. There are a lot of people who don't travel and people for various reasons can't, and that's not a problem. But I just think it's healthy and a good growth exercise anyway to go and do other things. And there also is a bit of the OE bias. When you come back and you're applying for a fellowship, well, it does sound good to say I was at Oxford. It just does add to your kind of kudos and credentials. And there were things that I could do there that just didn't exist here. So, getting introduced to a professor of zoology and chatting to people at lunch about spider behaviour and crows, but, doing infectious diseases modelling, it was just nothing I could have done at home. So it was great. So take the opportunities, yeah.
I think we've got one last question we'll take.
Yeah, so sorry, 2 questions. Firstly, Jodie, how do you define the difference between a sponsor and a mentor? Mm-hmm. And then secondly, I think as STEM people, we understand the importance of evidence and data, but communicating that with politicians and people involved in strategy, so many of them don't come from this sort of background. So how did you get them to sort of buy into the evidence?
Really good questions. So firstly on the mentors and sponsors, I think we all need many, many, many mentors, and you can have mentors who are your peers and mentors who are the next level up and mentors who are many levels up, and they're people who you go to for advice and guidance and they help you to craft and shape your career and think about what your strengths are and other things, and your strengths are the things you love. They're not just the things you're good at. You can be good at things that you find boring, but, you know, they're the things you love that keep you coming to work. Sponsors are the people who are prepared to take that and push you forward for things. The people who will say, oh, no, I can't speak at that meeting, but ask Jodie. She'd be available and do it. And so it's one of the really fun things about getting old, that you can sponsor people and you can say, oh, I've got just the right person to be the editor for your journal, or, you know, this person should give a talk, or you can help join the dots and make opportunities for people. That's what sponsors do. And then on the communicating advice to non-technical people, that is just a constant learning journey. And, you know, like I said, it's great to have data skills, but communication skills are also key. I got into medicine on English Lit. I did debating and public speaking, and I remember getting into medicine and thinking, oh, what a shame, I'll never do that again. You know, I write persuasive text my whole life to get people to give me money or to make a policy decision. So it's just a constant learning journey, and I think we need to actively. I'm really pleased in a lot of science degrees. There are now science communication subjects. Take them. Learn to write. Learn to write for you know, non-technical audiences. I write for The Conversation and other things, and those editors are really good at helping. But also working with advisors and other policy people, like Brendan Murphy, Chief Medical Officer at the start of 2020. We would take our modelling advice, we'd write a nice report, we'd think it was really plain, he'd look at it and go, looks like a James and Jodie thing. And then he'd make it really, really simple. And he's the one who taught Scott Morrison to tell people what our effective was. So you can always learn, always take feedback. Julie Leask is an amazing woman up in Sydney who's expert at communication. She was my back pocket friend. If we had a new message that was complex, it's, can I run this by you first? And that's, you know, to policymakers, but also the public. How do you communicate without raising barbs? So learn, just keep learning. Yep. Sorry, I went over.
No, that was great. Having those allies is really important, and it's a big theme we're talking about. Thank you so much, Jodie, for your time.
Oh, thank you. Lovely. Thanks very much.